we're going to go fast through all of these, we're going fast through all of these. But don't take how quickly we're going through this as a sign of, or as an indicator of the level of importance of the material. We talked about prone for an entire day. We spent a whole day on a single posture. We spent a whole day on pushing down and head control and all of that. And we're flying through the fascial lines. Doesn't mean that prone was more important or more detailed than any of our fascial lines, but the fascial lines are just a little bit more straightforward. Here's the information. Step one in understanding the fascial lines is first and foremost knowing which one of each, knowing what is included within each fascial line. Until you know what's included in each fascial line, then we can't actually, you can't understand what that line does. So right now we're just in the, here's the contents, here are the things to be aware of, here are kind of some areas to pay attention to, phase of discussing the lines, and then like I said, once we get through this stuff, the lectures, we're going to go down and we're going to start doing hands-on stuff with all of these. Why that's important is, use dry needling for example. Taking a needle, sticking it in a tissue for a specific reason doesn't take a whole lot of skill. I don't mean this in a despairing manner, but when I went and got my flu shot, I've had students give me flu shots before. How hard is it to stick a needle in to a tissue? It's not. So from a dry needling standpoint, putting a needle in the tissue is you're just putting a needle in the tissue. That's been done for literally thousands of years. There's nothing special about it. There's really very little skill in it. Poke a needle in. And then you have to advance the needle, be able to feel through that needle what tissue you're getting at. That's not a large skill set. There's more skill involved in taping an ankle and not getting wrinkles and making sure you're maintaining the tension of it. From a skill standpoint, there's more skill involved in taping an ankle than putting a needle in tissue. The skill of dry needling is understanding the anatomy and the mechanics of it. Because if you put the needle in the wrong place, you just put a piece of metal in the tissue. That's not going to do anything. So when it comes to, and why I use dry needling, is just because that's probably the lowest skilled technique that we have. But it's also the one that right now is one of the hottest topics from a manual skill standpoint. And it has nothing to do with putting a needle in tissue. I can pull out needles right now and I can certify you guys all in how to advance a needle into the tissue. High five, wonderful job. You can't needle anybody. You don't even have the skill. You know how to put a needle in. So any of the manual skills, we could say the same thing about Graston. I went through Graston training 8-9 years ago. They give you this piece, they give you this metal implement and you learn to scrape it on the skin. It's not that hard. A little bit more skill than putting a needle in the tissue, but it's not that hard. Cupping. I remember when I was, I'd have been a sophomore in high school. I lived out in the middle of nowhere, and so for school, we went school shopping, and we drove all the way to the metropolis of Columbia. It was like 2 hours away. And my dad had a stuffed animal that you stuck to the inside window of the car, and you could see it from the outside. And it had these little suction cups on it. Well, my younger brother thought it was hilarious when I would take the suction cup and stick it to my forehead. Well, I was keeping him entertained on the drive because we didn't have anything but windows for entertainment. And I kept sticking it on my forehead. He'd laugh. Well, eventually he fell asleep. Well, I forgot I had a suction cup on my forehead. So a suction cup on your forehead for 45 minutes as you're driving to Columbia, you get there, you take it off. Guess what you have on your forehead? You guys see that skill set? You have a nice third eye. I had a bruise on my forehead from the suction cup. How's that any different than cupping? It's all about the pressure. It doesn't take much skill. I was a sophomore. I was 15, 16 at the time. And that was my first episode of cupping. It takes very little skill. It's all in the understanding of the body and the physiology and the anatomy. And as athletic trainers, the anatomy that we're taught is, like I said before when we started the fascial lines, we need to know that. But understand, that's an anatomy for you guys to become an entry-level clinician, just to know where the bits and the pieces are, not how they function together. And when we talk about movement, because remember, why do people come see us? They come see us because they're in pain. If they have an acute injury, those are easy to treat. If it's not an acute injury, not easy to treat. You have to understand the mechanics. You have to understand how everything functions together. You have to understand how the biceps influences the knee, and vice versa. So that's why with the fascial lines, we have to understand anatomy. From a clinical standpoint, if you want to improve your clinical skill set, the best thing you can do is understand anatomy so well that there's no question to it. If you're having to think through what structures am I working with right now, your skill level in anatomy isn't where it needs to be. And that's okay. We all have to start somewhere. We will have to move forward with that. But you have to understand that probably the single most impactful thing you can do from a skill set is know your anatomy, forward, backwards, upside down, sideways, with your eyes closed. Watch Stranger Things in the upside down. Do you guys know there's a thing on Netflix called Stranger Things? Holy cow, I just got turned on to that. I'm on season 2, just getting started. It's awesome. I don't know why I didn't get into this earlier. Did that with Yellowstone. I watched all the Yellowstone episodes, all the seasons of Yellowstone in like a 72-hour period. And then watched it again. But anyway, we have to understand our anatomy. And understanding the anatomy and how the different components work together within the fascial lines ties in better from a movement standpoint than any other approach that I've come across in 25 years of practice. So that's why we're going to fly through this stuff so you guys have the baseline information. We'll talk about some of the important interactions of each one of the lines, some of the things that the lines do. And then we're going to spend hands-on with this because once we can start getting hands-on, it'll help you guys understand this a little bit better. So the last one of our cardinal lines we're going to talk about are the lateral line. Now understand, said this with the superficial back line, superficial front line. We often, especially with those two lines, we often think the superficial front line is just one line because your left superficial front line's right here, your right superficial front line's right here. They're really close to each other. Same thing, superficial back line on the back side. They're next door neighbors. So we often, it's even though there's two individual lines, it's very easy to think of them as just one functioning line, even though there's two. The lateral line, we talk about it as a lateral line, but now we're talking about the left lateral line and the right lateral line. The difference is now my lateral line is as far laterally on the body as we can get. It's as far away as it can be and still be in city limits. So the interaction between the two, there's a lot more interaction between the two because they're so far apart. If you have a difference in the left superficial front line, you have a difference in the right superficial front line, they could be way off because of how close they are to each other. It's not going to make a drastic difference. You might get a little bit of rotation at the pelvis at the left superficial back line, right superficial back line are off just a little bit. You might get a little bit of difference at the shoulders, but that's about the extent of what you're going to get because of how close those lines are together. But now we're talking left lateral line, right lateral line. If there's differences in there, we can create significant differences and significant shifts at the pelvis and at the trunk and at the shoulder and at the knees and at the feet and at the neck because of how far away they are from midline. So the interaction between the left lateral line and right lateral line, being able to balance those two out is very critical for us to maintain our center of mass over our feet. Like I said, this is as far laterally as we can get and still be part of our trunk, appendicular, axial skeleton. Don't get out to the arms or anything with this. Whether you call it the perineals or the fibularis, we start at the feet, work our way up, the longus and the brevis. The entire abductor group, GFL, glute minimus, medius, glute max. We have our internal and external obliques. The quadratus lumborum gets a little asterisk next to it because we consider it's the neighbor we like, but it's not part of the family. everything we do as a family, they're there, but they're not part of the family, so they're not included in a lot of the drama. So the QL is often considered as part of this line, but it's not formally part of this line. Intercostals, sternocleidomastoid, splenius capitis up at the neck. And then the scalenes live on the other side of the house. They're not part of the family, but we consider them as part of the line. Same thing. They aren't part of the line formally, but how they function and what they do at the neck, they do get a little bit of consideration in being associated with that fascia, with the lateral line on each side. From a bony anatomy standpoint, yes, I just talked about how the lateral lines are as far from midline as we can get, and we start at the base of the first, as close to midline as we can get. Peroneus longus wraps around to the bottom of the base of the first. So we have the base of the first, base of the fifth, fibular head. We move up to the knee, the lateral tibial condyle, ASIS, PSIS, and iliac crest. We're taking the whole lateral component of the innominate. First and second ribs, up to the mastoid process, and then up to the occipital ridge. Not a lot of other tissues associated with this. The iliotibial band, the IT band, whatever you want to call it, and then the anterior ligament of the fibular head. There's not a lot of extra stuff going on with this line. Easy way to think about the lateral lines, it's like a set of bookends on each side. It keeps everything mediated left to right. Interacts with the superficial front line. If we go back and we look at the tissues, sternocleidomastoid has a tie-in with the superficial front line. So there is that interaction with the superficial front line. When we get to and talk about the arm lines, there's going to be a lot of consideration with the lateral line. So the lateral line and the arm lines, because of what the trunk does, because of how the muscles that are involved in this, does have a lot of influence when it comes to the arm lines. Controls the frontal plane, basically keeps our center of mass over our base of support, left to right, side to side. Helps us with lateral flexion of the trunk, lateral flexion of the neck. It can abduct the hip, however, it's the only time that happens is if our foot is off the ground. So just from a day-to-day function standpoint, how many times do you guys actively abduct your hip? We really don't do it a whole lot. Maybe if you say I'm sitting in my car and I'm going to step outside, I abduct my hip a little bit. I'm hard pressed to come up with many other things from a day-to-day functional standpoint and how we abduct our hip. Really, even though it can act as a hip abductor, really what it does is it helps to stabilize the hip and prevent adduction of the foot. Because remember that old Trendelenburg gait, the Trendelenburg test, stand on one leg and you're looking for the hip. Basically, and we were always taught that that's a test of the glute medius strength. It is, but that's also like saying that there's one of you in this class and one of you is carrying the load for the whole class. What about everybody else? So that's not wrong, but it's a very myopic view of what's actually going on with abduction of the hip. So what the lateral line does, it doesn't necessarily, it can Jane Fonda our hip, but we don't use it like that more often, majority of the time. What it does though is when we take this foot off the ground, it prevents our pelvis from dropping. So it maintains that level pelvis. So it prevents the abduction. Eversion of the foot, and then decelerates lateral motions. This is the lateral line on the superficial front line. I forgot to change that. It's the final one of our cardinal lines. So our four cardinal lines, or our cardinal lines are superficial front lines, superficial back lines, and left and right lateral line. We talked about how there is a left superficial front line and back line and a right superficial front line and back line. But because, like I said before, because they're so close to midline, they don't have a very good mechanical advantage on controlling lateral movement. The lateral line, because it's further away, has a significant mechanical advantage in controlling that. So it is extremely important when we're talking about those lateral movements. You can't have a dorsiflexion limitation if you have issues within the lateral line. You can have a collapsed arch because, again, the peroneus longus, fibularis longus, whatever one you want to call it, loops around the bottom of the foot and inserts into the base of the first metatarsal. So it's even though the peroneals evert the foot, they're a huge supporter of the medial longitudinal arch. Any varus valgus of the entire lower extremity. I think if you're an athletic trainer, it's required that at some point in your career, you're going to go to either a district meeting, a state meeting, or the national meeting, and there's going to be the token presentation on preventing ACL injuries. Don't worry, it's the same presentation as it's always been since 1996. They just update the PowerPoints, but the message is exactly the same. And they're going to show the exact same black and white picture of a girl that jumps off of a box, and when she lands, her knees go like this. And it's required, when you see this, for there to be a collective, because it happens every single year, at least every time I've been to this presentation. So anytime you see any kind of valgus of the knee, valgus collapse of the lower extremity, you're looking at a lateral line issue. What I think is ironic, though, is we all give the collective ooh and ah when we see the knees run into each other because, that's so problematic and when we have a valgus collapse, that's horrible, but nobody does anything when the medial arch is touching the ground. It's the exact same issue. The valgus collapse of the foot. Apparently, the valgus collapse of the foot is the black sheep of the family. Nobody cares about it. Let it hit the ground. But as soon as that knee starts to come in, we have big issues. So any kind of valgus collapse of the lower extremity, it's all equally bad. Whether it's a valgus collapse of the knee, because if you have a valgus collapse of the knee, what does the foot have to do? It has to collapse. And if my interaction with the ground is starting with a foot that has no arch, or a foot where as soon as I make contact with the ground, the medial side of it comes down to the ground, it's pulling my knee into a valgus position. So we see the knee, it's a foot issue or a hip issue. The knee can only do what the foot and the hip are doing. Lateral shifts of the pelvis, lateral shifts of the trunk. You'll occasionally see people that come in with back issues, back pain, and you'll see them walking around like this because this is comfortable. They have a huge lateral shift with that. Lateral side bend. If I have a lateral shift, I have to have a lateral side bend to keep my head and everything vertical, because otherwise I'd be walking around like the old V8 commercials. So I have to have that lateral side bend when that's present. And then because the sternocleidomastoid, it can contribute to that forward head. After we talked about both the superficial front, superficial back lines' ability to work with each other, it's very similar. Yeah, I didn't update this one either. The balance between the left lateral line and the right lateral line. The interaction between the left line and the right line and their ability to mediate what the other one is doing is extremely critical when we're trying to maintain our base of support, our center of mass over our base of support. Now, that's all well and good. And my lateral lines, as I'm standing here right now, my lateral lines, it's not that big a deal. There's not a lot of forces that are trying to pull me outside of where I'm trying to stand. What changes that? The world's spinning. We're not going to have a whole lot of side-to-side movement. What immediately ramps up the activity of my lateral line? Why locomotion? More than asymmetrical.
Separate.
What do you mean by separating more?
Like your distance between those lines is farther away.
The distance between the lines becomes further away. Now, as I'm asymmetrical, my left lateral line and my right lateral line are doing two different things, basically from the neck down. Even though it looks like obviously from the waist down they're doing two different things, but we're also having to control things in the trunk and the neck differently. So we are getting a difference in what the lateral line is doing here. So we're changing things, and that interaction becomes even more important. But what's going to immediately ramp up how active that lateral line is and how influential that lateral line is in maintaining my center of mass? It's tied to locomotion, because if I'm here, what's the next thing I have to do to get to there? What was that?
You're like on one base of support.
Single leg stance. Here, in symmetrical stance, my right lateral line and my left lateral line have to work together. But it's not that hard because there's not a lot going on. Now, if I'm on the bear line and I'm riding across campus and I'm standing and we're driving this way and I'm standing this way, as we stop and go this way, I'll have a lot going on there. But if I stand this way, the only time I'm going to have a lot of side-to-side movement is when I'm going around the corner. So symmetrical stance, okay, we have a little bit there. Asymmetrical stance, now that coordination takes a little bit more work, because now my left lateral line and my right lateral line are doing two completely different things. And in order to maintain vertical, they have to work in a coordinated manner to maintain that position, to maintain my level head, to maintain everything else. But now, as soon as I switch to single leg stance, my left lateral line is doing something completely different than my right lateral line is. My left lateral line now is doing we won't say 100% of the work. My left lateral line is doing like 99% of the work. Because my right lateral line is still having to work with the left lateral line, but it's not anchored to anything now. So it's having to work off of the pelvis, which is solely being anchored by that left lateral line. Lateral line from the waist down on this right side, it's really not doing anything because it's not on the ground. It doesn't have anything to operate off of. It doesn't have anything to contribute to the situation. But from the pelvis up, the rest of that right lateral line has to be able to work with the left lateral line to maintain that vertical. The only difference is now it's not anchored to the ground, so it has to be anchored to that pelvis. So it puts even more focus on that left lateral line for that moment where I'm in single leg stance. And then it switches to asymmetrical, and we repeat the same thing on the opposite side. And gait becomes a series of that happening rather quickly in a coordinated manner so that we maintain that vertical position. So when we're talking about the lateral line dominating an activity, because when we talk about any activity, all the lines are always functioning and doing something with everything that we're doing. If we're doing something like a deadlift, it's really a matter of the superficial back line, superficial front line working together to pull that off. When we're talking about anything in an asymmetrical position, now all the lines are having to work together. None are really more dominant than the others. None that we've talked about yet are really more dominant than the others. But as soon as I go to single leg stance, the left lateral line is now essentially the left lateral line becomes the group leader and has to coordinate everything else. And how that left lateral line functions and how they go determines how everything else is going to go. So as soon as we go into single leg stance, that lateral line that's in stance becomes the dominant lateral line of that activity for that moment in time. So from an athletic training standpoint, from a rehab standpoint, whenever we're talking any kind of single leg balance, you're doing a lateral line intervention. Doesn't matter what your intent is, you've created a dominant lateral line, which is wonderful. But think about when we typically do single leg balance type activities. It's because I hurt my left ankle, I hurt my left knee, I did something here. We're going to spend a lot of time single leg stance on my left leg because it's the bad leg. How much time do we spend on the right leg? We typically avoid it. And so when we're doing this, to address the ankle, to address the balance issue that we identified on this left leg, we're addressing that, but now that balance between the left lateral line and the right lateral line, even though we're trying to fix balance, we're creating an imbalance because now that right lateral line is not getting any attention. So we have to keep in mind, if we're doing something single leg stance on the left side, we need to touch base and make sure that we're doing something on the right side as well to offset that. Otherwise, we might be contributing to a larger problem. All right, at the foot, we're all familiar with ankle sprains. The lateral line supports the static structures. When I say supports the static structures, if the lateral line does its job, well, anytime we have dynamic structures, I say dynamic structures, structures that are capable of shortening and lengthening. So our lateral line. Anytime we have dynamic structures and static structures, the ligament to joint capsules, that are creating a controlled environment around a joint, the first line of defense is always the dynamic structures. If the dynamic structures do their job, the static structures don't get overtaxed. Now, if the dynamic structures can't do their job, we still have to provide support to that lateral ankle. And why do we have to provide support to that lateral ankle? Because it's all about maintaining our center of mass over a base of support to prevent a fall. Because spraining my ankle is less of a threat to the system than a fall where I hit my head on the ground. So if I'm coming down, if I'm landing, if I'm stepping, my lateral line is the first thing that's creating that control of the ankle to keep my center of mass over the base of support. If for whatever reason it's not able to sufficiently do everything that it needs to and it needs some help, then the static structures of the lateral ankle, ATF, the calcaneofibular ligament, posterior talofibular ligament, then those have to start bearing some of the load. As that load continues to shift from the dynamic structures to the static structures, eventually what happens to those static structures? You damage them. You either tear them or you avulse them because the forces are too much. They're static structures. They can't elongate. And if there's enough force to create enough motion that they need to elongate, the only way they can do that is for the fibers to tear or for there to be an avulsion. So why is that important? Well, from our standpoint, how often do we deal with ankle sprains? That's like the first thing we learn about in ATC 101 or entry-level athletic training or whatever we call it in our programs is ankle sprains. We learn how to tape them. We learn how to assess them. We learn how to do rehab. That's kind of the foundation of being an athletic trainer. But if we get to the point that we've gotten an ankle sprain, we know there's a lateral line issue. And we know that there was probably some deficiency in the lateral line that contributed to the fact that we have an ankle sprain. Because if the lateral line could do its job, it bears the stress doesn't get passed on to the static structures, and the static structures don't end up being overloaded. When we get an ankle sprain, when we see damage there, we know that the forces were transmitted to the static structures, which means we have an issue with the dynamic structures, the dynamic tissues, the lateral line. Which, that's not new information. The problem is, let's just strengthen the lateral line. Solved. If you're saying that this is an issue with the lateral line structures and they're not able to do their jobs, how do we make them more robust? We make them stronger. And I'm going to go back to the same discussion I had when we talked about dorsiflexion. Size of the gastroc versus the size of the anterior tibialis. Anterior tibialis is never going to win that fight. How big are the perineums? Probably about like that. It's probably a good representation of what your perineals are like. Now, how strong do you think your perineals are? Not strong enough to move your body weight. Your perineals can usually, if you've been focusing and training your perineals, you go to the gym and you have perineal day and you spend some time working on that, you have perineals that can generate 25 to 50% of your body weight in force. It doesn't take, we're talking like third grade math, 240 pounds, 55 pounds of force. Which one's going to win? 235 is always greater than 55. My perineals aren't strong enough to hold me up. Where does that extra force come from? It's where the lateral line comes into play. And remember, when we look at the perineals are not designed to be a strong muscle. If they were, they'd have a bigger muscle belly. The pination would be in a different angle. The perineals are designed to support the arch of the foot. The tendon wraps around. The perineals are designed in a manner that they have to create stability and control at the ankle. A muscle that's designed to create control and stability isn't designed to be a strong muscle. It's designed to be a muscle that turns on and turns off really, really quick to direct the forces. And when the perineals can do its job, the perineals themselves aren't decelerating my body with this. The perineals aren't strong enough to decelerate my body. What the perineals are strong enough to do is to redirect the forces and pass the forces, move those forces, transmit the forces past the ankle up into the lateral line. And guess what happens when we go far enough up into the lateral line? We hit the IT band. The IT band spreads out. We get glute minimus, glute medius, TFL, and then the giant glute max. Glute max can generate enough force to control the body weight. Nothing else in the line can. So what we've done wrong as a profession is we have tried to strengthen the perineals. And again, I'm not saying the three-way ankle exercises are bad. Not at all. They will not accomplish what we think they're accomplishing. And even if they do, even if you work them up to where they're using the gray or the silver, whatever the strongest TheraBand is, and they can do 100 reps on that, and you've got the strongest perineals on the planet, that's wonderful. It's still only 50% of their body weight at max. They're still not strong enough to do the job they need to do. And if you've done anything, you've actually made the problem worse. Because you trained a stabilizer to now be a prime mover. And that's not its function. Somebody has an ankle sprain, it's a great idea. Those 3-4-way ankle exercises are wonderful, but not from a strengthening standpoint, from a blood flow standpoint. You get the repeated contractions, we're increasing blood flow, we're passing forces on there. That's the benefit of the 4-way, the 3-way, whatever way exercises at the ankle we're going to do, not to strengthen. So when we start talking about the perineals, we have to start talking about exercises, interventions that work on the timing of the integration, not the ability to generate large amounts of force. We need them to generate enough force rapidly and quickly. Because we've all done this. We go and we take a step, and we either step wrong, or there's a little hole, or the curve's at a little bit different angle, and we feel that start to roll, and we do this weird pitch, and we catch ourselves. That's your lateral line. It just saved you. When we do that weird pitch that starts with the perineals, they have sensory input that something's not going on well here. We're in a compromised position. If we don't change things, the lateral ankle is going to have to bear the burden of this. It's not going to be able to. We're going to have an injury. So what ends up happening, we do this weird kind of off balancing, we kick our hips out, we do whatever, we step funny, all because the perineals got that sensory input, redirected forces appropriately up into the lateral line. It caused a ripple effect, and as a system, we dissipated those forces so it didn't go into those static structures of the ankle. We've all seen those times somebody jumps up for a rebound and they land on somebody's foot. And we see that happen, and we see it immediately come back. And you immediately you're like, oh, they just sprained their ankle. And then they're fine. Because they got to we see it happening, we see it, this is not going to be good. But at the same time, the perineals sense what's going on. They get the input, they create a quick response. You see a shift of the body, and you see that come back. Now, it might be a little sore. And then we test them, but the static side of the ankle, the static structures are okay. It's because those muscles were quick. It's because that line worked together to transmit the forces away from the static structures of the ankle. So we need these structures to be fast. They can't be fast if we train them to be prime movers where we're doing this kind of stuff. I'm not saying there's not a time and a place for this. There is. From a blood flow standpoint, from a sensory input standpoint, all of that's wonderful. But if we can't have it in our mind that we're strengthening those tissues. Because even if you do an amazing job, a third of their body weight, maybe a half of their body weight, in forces that you're creating, you're not going to get them strong. Seems weird, but the lateral line is a significant contributor to the support of the arch. Proteus longus loops down, this is the base of the fifth, the lateral side of the foot. Proteus longus loops behind the lateral malleolus, down along the base of the fifth, behind the base of the fifth, comes in and attaches to the first cuneiform base of the first metatarsal head. So it loops underneath, it helps to support that lateral arch, it helps to support the arch of the foot. Proteus brevis, shorter, comes down, loops around the lateral malleolus, comes in and inserts on the base of the fifth. You see that area in red, just because base of the fifth fractures. We're fairly sensitive to those. Now, the thing that's important to understand, once these tendons drop below the lateral ankle, so once they wrap around, once they're below the level of the ankle, they can't really exert much force. So whatever they do here is mitigated by what's going on up above. You're not going to see a whole lot going on down here unless we address the tissues up above. That's why if you have somebody has tissue problems in their perineals, they're going to likely have issues in the bottom of their foot as well. There's not going to be uncommon if they develop issues in the bottom of their foot. If you have poor tissue quality up above, it's going to have a negative impact on the arch and the integrity of that arch. If you have somebody that has a fallen arch and when they get out of a pool, it looks like Daffy Duck walked around, you can't see any kind of an arch. We think about that from a mechanical standpoint, what that does. Well, you know, the navicular drops down and it changes the structure of the foot and it changes what's going on with the knee. Yeah, all of that, that's a simple part. But what we don't comprehend and what we don't value enough is what that does to the sensory input. Your navicular is not supposed to touch the ground. Your navicular is not supposed to give you a lot of input about what the quality of the ground is because it's not supposed to know. Your navicular is not supposed to be compressed into the ground. That's why it's on the medial side of the foot. It's supposed to be up off the ground. When we compress the navicular, when we compress this area of the foot into the ground, it's going to be painful because it's not designed to do that. So we're going to get lots of incorrect, inappropriate sensory input. It's going to be very sensitive to what's going on. So that person that has an arch that's compromised or a collapsed arch, and they start to get stress fractures in their foot. Yeah, they have stress fractures. We're not surprised. We can't be surprised. What we don't value and what we don't appreciate is what's that doing to the sensory input of the entire rest of the foot and the lower leg. It's going to compromise things. Then also on top of that, this part of the foot's, again, not supposed to be in contact with the ground. When you compress it into the ground several thousand steps over the course of the day, that is going to create an ischemic environment. We're going to have crappy tissue quality. So now you have crappy tissue quality. Ischemia, hold your breath as long as you want to. You're not going to like it. Ischemia is never a non-painful situation. Anytime we're talking about ischemic tissue, it's creating pain. It's creating a noxious response. So as soon as we start to have tissue ischemia because of the compression that we're getting over the several thousand steps of the day, that's going to magnify the sensory input, and now we have all kinds of issues. E-stim and IX isn't going to fix this. There's not a manual therapy we can do to fix this. Now, there's manual therapies that we can do to improve the tissue quality. But the only solution for this is to get this off the ground. So we have to find a way to support that arch. And it's not necessarily going to be with an orthotic or anything along those lines. Base of the fifth, talk about this. Base of the fifth fracture, we're always concerned about that, and rightfully so, because again, base of the fifth fracture, because of blood flow to the tissue, it can create, or the situation is primed to develop a non-union type fracture. But we also have to consider that for females, at the age of 10, we start to see a growth plate hypothesis on the lateral aspect of the fifth metatarsal. In boys, we start to see that around the age of 12. We start to see this growth plate. If you look at this and you don't know that that's a growth plate, that looks just like a fracture. This is misdiagnosed many times. Many times. A lot. Especially in that 10 to 14-year-old age groups of females, 12 to 16-year-olds in males. Here's a deciding factor. This is an actual fracture. Look at the direction it's running. It's running oblique to the bone. That's a fracture. It's basically the fifth fracture. This is an open growth plate. Now, we could probably have a discussion, is there a growth plate fracture right here? Because this fracture looks like it's moving through. We could have that discussion, then there might actually be a Salter-Harris type fracture right here. But if we image this and we don't see this, and all we see is this is a growth plate. It's going in line with the metatarsal. Very important for us to understand that, especially if you're working in this middle school, early high school population, because I've seen several kids, unfortunately, that they come in, they have the mechanism, they have pain over the base of the fifth, they get an x-ray, this is what it looks like, we pin it. And they pin the growth. And guess what that causes? Lots of problems. Now, it's not going to create a giant disruption in growth because there's not a lot of growth that happens from here, but you're pinning the growth plate and it is going to create some problems. So we have to understand, especially when we're dealing with this age population, that we do have a growth plate here. It looks a lot like a fracture, but we have to understand fractures of the base of the fifth. A Jones fracture is going to run oblique to the bone, not in line with the bone. So we have to understand that because one of those requires possibly pinning, the other one we just need to let it calm down and keep an eye on it. We don't want to jump straight to surgical options. I can't also say every single one of those times when I've seen this get pinned when it wasn't an actual fracture, it's led to long-term pain and problems. When I say long-term, usually 2 to 3 years before pain completely resolves after the surgery. It's a very frustrating situation for the patient because I thought this was going to make it better. It's actually made the situation worse. At the knee, we move up lateral line up into the knee. You'll notice that when we talked about the accessory structures, the LCL wasn't included. The LCL is not a part of the lateral line because of, as those forces come up the perineals, they go into the fibular head, and remember, the IT band fans out and attaches all the way, the lateral aspect of the tibial tuberosity, all the way into the fibular head. So the line of force goes fibular head, up into the anterior ligament of the fibular head, into the tibial condyle, into the IT band. So the direction of force bypasses that lateral LCL. Now, the LCL does provide static control of the knee.
I found this on the web.
Wonderful. Occasionally, the LCL is congenitally absent. When the LCL is injured and torn, this cord-like band is not as noticeable as on the unaffected side. Who knew? The LCL is a static structure of the knee. So all the discussions that we had about the ankle, the static structures of the ankle, and how the lateral line helps to support that, we can have that exact same discussion here. It's just not a part of the line. So it does help provide some dynamic support to the LCL. You guys all learned of the hip deltoid? And when we think of the deltoid and we think of the shoulder, but we have the exact same structure in the hip. We learned the IT band as being an extension of the tensor fasciae, correct? The IT band inserts into the TFL. Yeah, it does. That's one of the structures that it inserts into. You're not getting a complete picture from an anatomy standpoint of this. The IT band actually inserts into the TFL, like we say, into the anterior fibers of the glute max and into the fibers of the glute med, which sits behind both of those. So the IT band actually has 3 points of origin: the TFL, the glute med, and the glute max. As the IT band, so at the hip, the IT band is very wide and it's very thin. As it progresses down to the knee, it starts to get narrower and it becomes more cord-like until it gets to the knee. And once it passes the knee, it fans back out and it inserts into the, like I said, tibial tuberosity all the way back to the tubular head. There is no possible way to stretch it. You cannot stretch the IT band. The IT band itself is a thick, fibrous tissue that is completely incapable of any type of elongation. You can foam roll it, but the foam rolling isn't going to create any change to the IT band. When I foam roll my IT band, it feels better. It does. Clinically, it does. Can't argue that. But it feels better because you're changing the environment. You're changing the sensory input. You're not changing the tissue length at any level. Plus, if you stretch the IT band, you're going to completely destabilize the entire lateral line. If you stretch the IT band, you're going to make it harder to create lateral stability of the ankle, lateral stability of the knee, lateral stability of the hip. Because now you've taken this structure, you made it longer. So now I have to do this to get a level of tension out of it that's normal. You're making the problem worse. So even if you could stretch the IT band, let's just say everything I said was wrong. Let's just assume I'm wrong. Everything we found is wrong. You can stretch the IT band. Let's assume that's the world we live in. You can stretch it. It's a dynamic tissue. We can elongate the IT band. Mechanically, that's absolutely ludicrous. It would make whatever situation you're trying to fix absolutely worse. So even if we could, there's no clinical reason to do it. None. Now, you can't stretch it, but we can improve the hydration of the IT band, and that's extremely important. We can dramatically change the sensory input. That's extremely important. That's one of the reasons why when you foam roll this, when you take the hypervolt and you do stuff over this, when you grasp in this, that's why it makes things better, because we're changing the sensory input. We're not changing the tissue. We're manipulating the sensory input. If we're going to have a discussion about the IT band, though, there is a mysterious fourth component of the IT band. Any guesses as to what it is? How many of you were going to say the vastus lateralis, the posterior quad? Vastus lateralis sits directly behind the IT band. So if we think about it, it goes skin, subcutaneous tissue, IT band, vastus lateralis, vastus intermedialis, femur. The IT band sits right on top of that vastus lateralis. This yellow line, highlighted in blue, these two lines, these two areas are very critical from a treatment standpoint. What do I do if somebody has IT band tendinitis? Well, first off, it's not a tendon, so the name's wrong. And if it doesn't have the 5 properties, the 5 signs and symptoms of an inflammatory reaction, it's got the name wrong and it's got the diagnosis wrong. It can't be IT band tendinitis. Let's just assume it's IT band tendinitis. I have to do something to make this feel better. Wonderful. You can't stretch it. You don't want to stretch it. We need to do something to it. What can we do to it? We can address its interaction with the vastus lateralis. The anterior side of the IT band, where it interacts with the vastus lateralis. The posterior side of the IT band, where it interacts with the vastus lateralis. Those tissues have to slide and glide. We're not going to get a lot of superior inferior sliding and gliding, but as I move my hip forward and back, that IT band needs to be able to slide anteriorly and posteriorly over that vastus lateralis. If it can't, and that gets tacked down, you have an IT band that's not moving the way that it's supposed to. Well, what do you think happens when that situation comes up? It's going to be uncomfortable. You're going to have deep, dull, achy pain in the side of your hip. You might have it more on the outside of your hip, greater trochanteric bursitis, or whatever you want to call that. You might have lateral knee pain. But it's because that IT band isn't moving anteriorly, posteriorly the way that it needs to over that vastus lateralis. This is an area that is highly likely to develop adhesions. To tack that down, why? I don't know. So if we go after and treat this interaction between the posterior vastus lateralis, between the vastus lateralis and the posterior border of the IT band, and the vastus lateralis and the anterior border of the IT band, we can create an improved sensory input to the area, and we can also improve the adhesions and the tissue sliding and gliding. We can dramatically change what's going on. How do we do that? Depends what your skill set is. But if let's just say it's Graston. Let's just say it's manual work. We're using our forearm and we're working on that IT band. Well, the patient feels that. And obviously, if the patient feels it, it's working. Remember, this is an area that's pretty sensitive to begin with. Just because they're feeling it doesn't necessarily mean that's clinically beneficial. We can do that same technique, but instead of going right over the IT band, we need to modify it, and now we're going over that point of interaction. And we're working some kind of sliding and gliding of that tissue while we're doing that. We're doing the same thing on the backside. We can dry needle this area, that interaction. I don't necessarily want to dry needle the IT band. I want to dry needle where that IT band and that vastus lateralis, that interaction occurs. If I'm going to do cupping, I want to do the cupping over this area. If I do a voodoo band, if I do a voodoo wrap and put that over there, I have to have some kind of movement of that IT band over that vastus lateralis because I have to improve the sliding and gliding properties of that tissue, not elongate the tissue. We have that patient has my hip snaps, snapping IT band. That's basically when somebody has that or you feel that, that's the IT band saying I'm adhered down somewhere. I'm not moving the way that it needs to. I can't appropriately slide and move anteriorly, posteriorly in a coordinated manner like I need to. I'm tacked down, so now I can't do everything I need to. I'm going to slide over the bony prominence of the greater trochanter, and it's going to be painful. But what do? We address this. It's a problem in the tissue interaction between the IT band and the vastus lateralis, and this just happens to be drug around, and that becomes painful. Oh, it's not because it's tight. So as soon as we get up to the greater trochanter, basically we start to see a series of basket weaves. We should be familiar with basket weaves because when we learn to tape an ankle, we learn that there is a basket weave technique at the ankle. What does this basket weave technique do? So we have a lateral line that goes straight down this way. Once we get up to this, what do you notice about that lateral line compared to what's going on below it? There's a lot of crossovers and interactions. How wide is the lateral line down here? About like that. When we get to the trunk, it expands to this. And it expands because of those little crossovers. The intercostals and the internal intercostals and the external intercostals, the internal obliques and the external obliques cross each other. So that series of basket weaves increases the anterior posterior width of that line, which creates more stability. It now creates a small ability to create rotation and to control rotation of the trunk. The spiral line is the dominant line when it comes to that, but the lateral line is influential in that. So when we see this basket weaving technique, it's to create an increase in stability and increase in control from the pelvis up, which again becomes very important from a stability standpoint and being able to maintain our trunk over our base of support, and then also from a rotary component. From a balance standpoint, if we're thinking about the lateral line as a series of X's, if there's tightness along both sides of the X's, it's going to create a lateral type flexion. So if my internal obliques and my external obliques, let's just say they're tight, they're equally tight. That's going to create lateral flexion this way. If my external obliques are tight and my internal obliques are elongated, that's going to create rotation because it's now pulling me this way. So depending on what's going on, it can create a different presentation to the trunk, either true lateral flexion, where all the structures are equally affected, or a rotation where one component of the structure is elongated and the other one is stretched or short. So we can see it present itself a couple different ways. This is important also because it helps with, from a gait standpoint, maintain our efficiency. It helps with a deceleration standpoint. So as we're stepping through it, as we get that dissociation, that lateral line is supporting the spiral line to control this and then also decelerate it. As we increase the velocity of our gait, so as we start to run, the ability to control that dissociation becomes even more important in the efficiency of walking. At the neck, we have the sternocleidomastoid and the splenius capitis. They support the head. They're constantly active when we're walking. So the interaction between these four muscles, let's say four muscles, left and right sternocleidomastoid, left and right splenius capitis. The interaction between those four muscles are what allow our head to stay still and focused on an object or focused on a point of reference. When the splenius capitis contracts, it creates ipsilateral rotation. So if my right splenius capitis is contracting and it's shortening, it's creating right rotation. My left sternocleidomastoid is also shortening, and that's creating contralateral rotation. So my right splenius capitis and my left sternocleidomastoid work together to create rotation to the right, opposite to create rotation to the left. That's important when we're standing here and we're turning our head. That's wonderful. But over the course of the day, yes, we turn our head a lot, but over the course of the day, if we're up on our feet, if we're moving from place to place, really what's happening is those four muscles are working in coordination to maintain a still head, to maintain a visual reference of our horizon that's level, to keep the eyes pointed where they need to be pointed, to keep the ears pointed where they need to be pointed, and to keep the vestibular inputs steady. What I want you to watch with her is watch two things. Watch how much her head's moving and watch her ponytail. Because you're going to get two completely different pictures of what's going on.
I get a half a meal for my piece, you get a couple.
Where's the head moving? Not at all. Watch the ponytail. That was it. That was a lot longer.
I get a half a meal for my piece, you get a couple.
Head's moving. Why is her ponytail moving? Because there's force being transmitted up into the head. And we're seeing what those forces are trying to do. Nothing controls her hair. So the hair is going to move around as a good representation of those forces. But how much is her head moving? Not at all. Because the splenius capitis, sternocleidomastoids are working in coordination to offset those forces that we're seeing in her ponytail. Because if they didn't do their job, you would see a head that's moving all over the place. Bass Pro Marathon was this weekend. Had I been thinking about it, I would have pulled out my phone and not had to search for her up on the internet to get the video. If you want to see how efficient somebody is at their running techniques, just watch their head. The more their head moves, the less efficient they are at running. You'll see people that when they go like this, you'll see this. They're not very efficient. Everything's moving. All of these sensory inputs that we're needing to get are all over the place. That requires a lot of effort then for me to stay upright. The kid I was talking to you guys about before that ran 80 meters to get a 40-yard time where he was turning his head all over the place, not only were his sternocleidomastoid, the splenius, not working, they were working opposite of what they needed to be. They were completely uncoordinated. So the more efficient somebody's running technique is, the more quiet their head is going to be. You won't see any movement because it's keeping a visual horizon that's level, it's keeping the vestibular system level, it's keeping the ears pointed where they need to point, so that we're getting as much appropriate input as we can get, and we're maintaining the quality of that input. Because as soon as this starts moving, now it makes it harder for everything else to do its job, because the world around us is literally moving, at least from our perception. Levator scapula is not included in this line. Any idea why? Because levator scapula runs parallel with the splenius capitis. Like, they literally run right next to each other. And they come up and they insert in almost the exact same place. They're right next to each other. Why is the levator not in the line that splenius capitis is? What's the splenius capitis anchored to? What's that structure right there? One of our vertebrae, right? What's the levator scapula anchored to? Scapula. So my levator scapula contracts and shortens. Is it going to pull the head down? No, it can't, because the spinal column's there. I can't move the head down. So when the levator scapula contracts, what's it do? It levates the scapula. It's literally in its name. So if the whole function of the lateral line is to maintain a head that's still and steady and efficiency of motion, we need to make sure that those muscles that are controlling the head have a solid anchor point. This isn't a solid anchor point, because as soon as that starts to contract, we now move the shoulder up, and that changes a lot of things when you get into the arm lines. We have to understand, even though it runs parallel, and it's at about the same depth, it's not included as part of this line because it doesn't support the function of the line. It actually is the opposite of the function of the line. Instead of maintaining a head that's still on an anchored axial skeleton, what ends up happening is the head is the anchor point, and we're trying to tug that shoulder up to the head. That's also one of the reasons why we get the issues in our neck that we get when we sit and when we carry our stress here. From a postural standpoint, we see the lateral line start to develop when we get to the top three postures, so sitting, kneeling, and stance. In sitting, we start to have a vertical trunk and a vertical head, so the upper components of that lateral line learns what a vertical trunk, what a vertical environment's like. The hips become vertical in kneeling, so we see the middle portion of the lateral line develop there, and then we see the lower part of the lateral line develop in standing. So we see the lateral line develop in all three of these, but we see it first develop with the head and the trunk, then the pelvis, then the legs. So just like other things that we've talked about, just like when we talked about the patterns, we talked about the patterns of the neurodevelopmental sequence, we prioritize the head and worked away. It's the same thing in the lateral line. We learn to control the head, stabilize the head, the trunk, then the pelvis, and the lower extremity. And we see that postural progression. Just like we talked about before, the lateral line is the most dominant when we're in single leg stance. The only time, so if we're talking about how to increase the dominance of the lateral line, single leg stance is the obvious answer. If we're not in single leg stance and we're trying to increase the dominance of the lateral line, we have to include or incorporate some kind of lateral forces that we're having to control. Not that we're having to create, that we have a force going this way and we're having to resist it. We have a force going that way, we're having to resist it. So we have to have some kind, if we're not in single leg stance, if we're in symmetrical stance or asymmetrical stance, there has to be a medial lateral force that we're having to maintain or control, or we're having to offset and mitigate. Questions about the lateral line? We're introduced to the lateral line very early in our athletic training education, that Trendelenburg gate, all about glute med. but glute med is only one of the 4 structures that actually contributes to a Trendelenburg. TFL, glute max, and then vastus lateralis through the IT band. So we have to understand that that's not incorrect, it's just a very myopic view of it. We can't just say it's truly just a glute med issue. All right, spiral line real quick. We'll get started on this and we'll finish it up on Thursday. As nice and orderly as the superficial front line, superficial back line, lateral line pictures are, the spiral line is none of that. It's all over the place. Things important when we start talking about the spiral line, that the spiral line is not original. The only portion of the spiral line that's not part of another line are the rhomboids and the serratus anterior. All the other muscular components of the line, which means also a significant portion of the bony attachments, are part of the other lines. So when we talk about the lateral line, internal, external obliques, TFL, perineals, all are part of the spiral line, but also are all part of the lateral line. Anterior tibialis, part of this line. It's also part of superficial front line. Biceps femoris, the spinal erectors, part of this line, but are also part of the superficial back line. So the only part of this line that is not affiliated with one of the other lines, with one of the cardinal lines we talked about, are the rhomboids, the medial border of the scapula, and the serratus anterior. Because of that, what the spiral line does is it helps to mitigate and control the rotational forces, the disassociation type forces that are involved in those other lines, especially when we're not in a symmetrical stance. So if I'm in a symmetrical stance, my spiral lines aren't really doing anything. The cardinal lines are maintaining this because left and right lateral lines are doing what they need to do. Left and right superficial front, superficial back lines are doing what they need to do. Superficial front line, superficial back line, they've got it worked out. They've got the situation under control. But as soon as we leave this position, and from a functional standpoint, there's not much that we do in this position. As soon as we leave here, the more asymmetrical our foot stance becomes, the more our spiral lines are going to be incorporated and involved in making sure that everything's pointed the direction that we need to point. Because the spiral line is going to be what keeps, if I'm in an asymmetrical stance, I want everything pointed straight ahead. I want my belly button pointed this way, especially if I'm walking. I don't want my belly button to be doing this kind of stuff when I'm walking forward. It's not efficient. Spiral line becomes very important as we go into asymmetrical stance, making sure that we're oriented where we need to be and offsetting the forces that are trying to pull us away from that. So now if we think about that, when I'm in asymmetrical stance here, spiral lines are making sure I'm where I need to be in an efficient manner. When I'm in asymmetrical stance here, exact same argument, just the exact opposite. It's the opposite spiral line. Lateral line is here. So when we think about gait, gait is about spiral line, lateral line, spiral line. Lateral line, spiral line. Lateral lines, we're just constantly going back and forth between the spiral lines and the lateral line that's offsetting and mitigating all of those forces that are trying to take us away from our base of support through rotation and dissociation. So when we think lateral line, single leg stance is the dominant stance of the lateral line. Asymmetrical stance is the dominant stance of the spiral line. Now, if we're still and if we're static, that's an easy conversation to have. If I'm standing here like this, it's spiral line. If I'm standing like this, it's lateral line. Where the complexity comes is very rarely am I just standing here like this. There's usually some interaction of the spiral line and lateral line as we're moving from point A to point B. So, symmetrical stance, cardinal lines. dominate the situation. Asymmetrical stance, spiral line dominates the conversation. Single leg stance, it's lateral line. Now keep in mind, all of those lines are working all the time. It's just, if I'm in symmetrical stance, the cardinal lines are the group leader. If I'm in single leg stance, lateral lines are group leader. And if I'm in asymmetrical stance, spiral lines are group leader. And we're constantly having to go back and forth and dynamically shift control as we're moving. How well do you think a group project would be if every 45 seconds there was a new group leader? But yet that's how we work it out from a movement standpoint. Last thing, we talked about all these muscles. The only original ones are the serratus, the rhomboids. Everything else is part of another line. I will say, basically, we start our path of the spiral line all the way up here at the mastoid process. So take your left hand, put it on your left mastoid process. We start our process, we start here. We go through the splenius to the rhomboids to the serratus, external obliques to internal obliques, over to the TFL, down the IT band, down the perineals, through the bottom of the foot, up the anterior tibialis, into the biceps femoris, up into the erectors. Now take your right hand and put it on the back of your skull on the right side to the occipital ridge. So we go all of that way to move from your right hand to your left finger. So this is the origin, this is where it finishes. All of the other lines, we start here and finish here. This one, we start here and we finish here. Or, there's a plot twist. We go the opposite way. But here's the really tricky part. We can start on this mastoid process. Now take this hand, instead of putting it on your right side occipital ridge, put it on the left side of your occipital ridge. Because it can come up the erectors on this side as well. So you can actually go through that whole trip to move a literal inch from the mastoid to the occipital ridge. We'll talk about that later. But wraps around the back of the neck to the shoulder blade, comes around the side, cross it. So we cross midline, upper thoracic. We cross midline at the linea alba. We come down here, cross midline at the foot, come back up into the sacrum. When we get to the sacrum, a decision has to be made. We either cross over and end up on the other side, or we stay on the same side and come up here. We'll talk about that on Thursday. All right, that's it for today. Any questions about the lateral line at all? We'll wrap up the spiral line on Thursday. If you have questions, let me know.